and some of the things I say will be becoming familiar. So first, who am I? I represent the research-based pharmaceutical industry, the European Association. It's based in Brussels, and I'm the Director General there since a year and a half, but I've worked a very long time in the industry. And I'm not going to say all the proper things about solidarity and equity with third countries and so on. I think that these are all the arguments that I can put forward to why we need to be engaged in the global health agenda also as an industry. Let me be a bit more serious and profound, and maybe also take the more long-term view. My companies, as you know, we have been around for 100 years, or more even, most of them, and we intend to be around for another 100 years. We still have a lot to do. So, despite that everything is on fire right now, and I get from Athens to Bucharest to Lisbon to Budapest last week, still we have to think long term, and many of the things we invest in, engage in, are really long term. And I'll try and address this from that perspective. So, first of all, and this was touched upon, but let's expand on it. I mean, research is global, science is global. You know, if you look at these breakthrough publications or number of publications that have come through just in the last 6 months on mapping various things. You know, we've mapped all the bacteria we carry. We carry about 4 kilos of bacteria on ourselves, and they actually play a role, a very important role, in all the cavities and in the guts. Now we know who they are and why they differ, and maybe there is even a link to disease or well-being. You know, there are certain links. We mapped the brain, the wiring of the brain. It's now for the first time mapped, which made my company. I think one of my companies, you wrote about that, Andrew. GlaxoSmithKline is now starting with an engineering department, microelectronics research. Very interesting. Think about that, repairing or going in fixing. So rather than at the gene therapy stage, I should go later on in the brain and fix things. It's absolutely thinkable. It's actually very realistic, actually, with nanotechnology and robots and everything years from now. Also, you've seen that junk DNA is not junk. I think we knew that. It's coding for other things. It's all the regulators for up and down and so on. And you have this gene string, you know. It's actually not a string, it's actually coiled. And so it means that the thing that regulates this gene is not here in this string. It's actually out here, but because it's folded, it's just across. This we didn't know. We could guess it, but now we have the map. So you can imagine the researchers in my industry, they are so excited. They've just begun, they say. So anyhow, and what has this got to do with it? Well, I'll come to that. Global, the research is global, the brains are global, people move around. That's obvious. Also, diseases travel. Communicable diseases certainly travel. It was alluded to earlier with influenza, with bacteria. And I want to use that as a case study here for why we in Europe have to care about the world, because these bacteria, they come here. So even if I come from Sweden, as you figure from my accent and name, we take pride in having one of the most restrictive uses in antibiotics. Only the Dutch are better in not using antibiotics, and that's all fine. We keep things in reserve, and we have very, very good. Sweden, very, very good resistance profiles. But it doesn't matter because we have tourists that come home from Kerala or maybe in a car accident we have home, they're full of germs. So these things are coming immediately back to all of us. So, and this is relevant for our discussion because this means that we need to find cures for all these diseases. And here it's about linking the early development scientists are maybe in Boston, but the patients are in Hyderabad, which means that we need to have a consortia of research around the world, including clinical trials capacity in these countries. EDCTP was mentioned before, and we're now engaged in designing the next EDCTP and the next framework program, and hopefully industry will take part. We put in order to address the problem with an empty pipeline of new antibiotics. The industry has joined forces with the European Commission, and we have now a close to 500 million euro project under IMI. IMI is Innovative Medicines Initiative, which is a 2 billion euro public-private partnership between the Commission and the industry, where we do pre-competitive research. So we identify areas where it's better if we collaborate in order to compete later. So everyone will put in their knowledge. This is what we do now for antibiotics. This is a big thing. So all the companies that still have something going on are joining forces. And it's easy said than done because you have to pool knowledge. We even bring back knowledge from companies that left the field, people that went into retirement or they have compounds that are in the library somewhere. You have to bring this back, systematize it, share it. It's going to take a long time. Now, in the extension of that, hopefully, we must be successful, otherwise we have a problem. That once we have these new antibiotics, we must preserve them. And it doesn't help if we have a good stewardship program in the UK or Sweden. We need a stewardship program in India where the patients are that will get the medicines. And there the concept of prescriptions is unknown. You go into a pharmacy and you buy whatever you want to buy. The prescription is just a reminder what the name of the medicine was. So, you know, we have to rebuild the entire distribution system, and we need to get pharmacists on board and physicians on board. So this is something that my organization is very much engaged in trying to get some kind of global compact or something for new antibiotics. Once they come, we must have a system in place. Now, I give this as sort of one exhibit for how everything's changing, and it's not an option, you know, should we work on global health? This is global, so my industry is definitely engaged in this. The other exhibit for engaging with these countries was also alluded to earlier. That's the whole concept of disruptive innovation. These people are forced to, in these countries, you're forced to think new. When I was in Sweden, I traveled several times with our health minister to different parts of the world. And we were on 2 trips I'll mention as examples. We went to Hyderabad actually and visited some hospitals. And there you could see it, how they maybe didn't use the absolute latest equipment, but it was good enough. And they had to rethink the way they deployed their staff. The nurses were used in a much more efficient way. The doctors were specialized in a whole different way. They used the hospital around the clock. They exploited the fact that people have different amount of money. So some people paid more for the same stuff. And they got a maybe better room to stay in and so on. So they have basically, like it's like on the planes, you know, first, second class, and third even. With the health, so that's in. So we can learn, particularly in time of crisis, we can learn how to maybe organize healthcare in a different way. The other example I'll give is when I was in Dubai with our health minister, and we met the health minister for the Emirates, and they were building then a Dubai health city. This was before the financial crisis, but I think it's still being built now. And they designed a hospital. They said we're gonna have patients come from all over the world to come here, so we're gonna be competing with in medical tourism. But in order to do that, we also need to have research, they said, because otherwise we won't get the best physicians here. We don't want to have people from Houston or from Oxford to come and spend some time in Dubai from time to time and see patients. They want to have their researchers there. And then it's the education. So they saw this system of innovation, the things that we dream about. Maybe we have it, you have it in this country, particularly in Oxford and Cambridge. Oxford is doing fantastic things in translation medicine right now. But elsewhere, you can't, because you've built your hospitals here and you have all people here. So they have a chance basically to leapfrog. You can also leapfrog technology-wise. Mobile phones were mentioned. Of course, if you don't have to sit there, you don't sit there with your mainframe computers, you don't have to sit there with your NHS IT infrastructure. Imagine if you go straight to iPads and the cloud. You know, you can really have a revolutionary e-health system for outcome monitoring and all that. So we can learn from these countries, and hopefully we can bring back. This could be more than selling the Blackberries and the iPhones to these countries. Actually, bring back the knowledge about how to use them and apply them in healthcare. So, I give you this as a second exhibit for why we need to. It's a two-way street with third countries. The third and last reason I think why we need to engage is because we need to find a sustainable model for medicines development. It is not sustainable, it is now, because we develop medicines and many people don't get them. which is a scandal in itself, of course. We have all these medicines we have developed that are off patent and should be cheap. They are cheap, but still people don't get them. So there's insufficient budgeting in many of the countries. We have some very modern access programs for some of the new medicines, but they're still not efficient enough. Why is this important? It's not only important because these patients need these medicines, it's also because I need, representing the research-based industry, I need some understanding and respect for my business model as well. I need these patents. I hate to put it on the table, but I need to have my patents. I need to have some years of exclusivity where I can make money, otherwise I can't invest. So in the market economy that we have, we need to somehow pay for innovation. And I hope we can discuss this in the panel, because I think the key to this is that everyone has to pay according to their ability to pay. We have rich people in the world, so Europe, US, have to pay more, of course, we do that. But also within countries. So in Brazil, you have people that are as rich as in Europe. They should pay their fair share of innovation. They shouldn't get it for free. Whereas you have the poor people in the favelas, you probably get it for free. So I think there is scope for, this is not the first time you hear this idea. There's been a number of very interesting ideas floated in papers. But I tell you that in my industry, the interest is really growing for looking at tiered pricing within countries and between countries in a whole different way. Many of my CEOs, such as in interviews that you've done with them, have very clearly expressed that this is something that should be advanced. And there's a limit to how much we can do ourselves with experimenting and our businesses. We need to explore some global framework for doing this. So this third aspect is important for the sustainability of medical innovation, that somehow there needs to be a buy-in for the fact that some people need to make money on this, in this model we have, while you make things accessible. And access is about having the right price for the right patient. And this is conceptually easy to say, it's very difficult to implement. We need to have this maintained support from the vendor public for doing what we're doing. Because no one else is going to develop medicines, to be frank with you. If the private sector is not investing in doing this, no one else is going to do it. So I'll leave it at that, and I look forward to the challenge.
Okay, thanks very much. And now, Anthony Kessel, the Director of Public Health Strategy at the Health Protection Agency.
Thank you. Good afternoon, everybody. Thank you for the invitation to come here and speak about global health. I've been given strict instructions here to answer this question: why is addressing global health important for Europe? And not do a show and tell about the Health Protection Agency. So I won't do a show and tell, and I will try and answer those questions, but I have to do it, or I feel I have to do it, by giving some examples, and they're quite practical examples, about health protection activities in global health. And I'm hoping that the three areas or reasons or explanations that I've provided are illustrated by those examples. I'm going to try and show why there are policy reasons, why global health is important for Europe, public health reasons, and moral reasons. Amongst other activities at HPA, amongst other responsibilities, overseeing our global health work is one of my areas. I have to tell you just a little bit about the HPA. People will know, some people will know already, it is the National Health Protection Agency. It becomes something called Public Health England in April next year, but its functions will continue. There's about 4,000 people. It's the national agency: infectious diseases, environmental hazards, chemicals, toxicology. Those are the divisions. There are about just under 60 sites around the country. That's my own division, Public Health Strategy, where we oversee global health from. My first reason that I gave you was policy reasons. And for us in the HPA, getting involved in global health work, when I say the HPA and global health, I'm focusing on the UK, but using UK as an example of why it's important for Europe. Two policy reasons. The international health regulations is the first one, 2005, put an onus on member states to respond to certain incidents, outbreaks, be involved in public health capacity building, and do, if you go and have a look on the WHO website, you will see, put an onus on countries with stronger public health resources to support countries with less public health resources. That onus is there. The HPA is the lead agency for the country in relation to the IHR. The second policy reason, and Nick may have touched on this morning, is we have a Health is Global strategy. We have a national strategy, cross-government, around global health. This is a good document. This was the original version. You can't quite see it, for 2008 to 11, I think, published by the Labour government. When the Conservative government came in, they updated that. It's got a very similar front cover, as you can see. People with children can spot the difference quite quickly. That logo's moved. But this is a very good document. It's on the DH website. Have a look at it. It is very good. I think it's very good anyway. It's straightforward. It's clear about the cross-government responsibilities. It mentions the Health Protection Agency specifically, and it talks about areas such as global health security and our responsibilities. So we have in the HPA 2 policy reasons, and in terms of discharging our responsibilities, for which getting involved in global health is important. The second reason I hope to illustrate are public health reasons, global public health reasons around the world. With support and strong involvement from the Department of Health's International Policy Division, I think Nick might have gone now, but over the last 5 years or so, we have built up a program of global health work, a global health strategy, and a program of work which we are proud of. And that has been divided into a range of projects that our staff, often working with partners in this country, but always on invitation from other countries, have been involved in. These are just some examples. You can see, oh, no, you can't see that. You can see in India, just as an example, we've got a project where we are working with the Public Health Foundations of India around training in responding to public health emergencies and training local staff in that respect. And there's a particular project here I'll come back to that's around chemical toxicology, building and some expertise we have in Europe in relation to that. We've got a range of projects around the world. We've also developed a range of staff secondments. This was something new to the HPA, new over the last 3 or 4 years. And I don't intend to go through the range of secondments we've got. They are in various countries around the world. You can see some of the examples here again in India. There's one working on South Pacific Islands and climate change, Commonwealth Secretary, and more that aren't here. But I just want to use one example of, it's this one here. A colleague of mine, Chikwe Ihekwahatsu, who is one of our consultant epidemiologists, and he's halfway through a 2-year, he's a senior member of staff, halfway through a 2-year secondment to the National Institute of Communicable Diseases in South Africa, NICD. And through this secondment, he has, over a short period of time, become co-head of their TB centre. This is the sister institute to HPA, the South African equivalent. He's become co-head of their TB centre, and he's been working on a substantive programme of work on multi-drug resistant TB in South Africa and its relevance to other countries, including to Europe. And just to show you here, multi-drug resistant TB, which is a global health issue, not just South Africa, it's UK, it's Europe as well. You can see here, this picture shows multi-drug MDR resistant TB as a proportion of all TB cases in particular countries. If you are red, like some of the Baltic countries, but also others such as Azerbaijan, you have a low TB burden, total TB, but a high amount of multi-drug resistance. If you are South Africa, South Africa has a huge TB problem, a lot of it coexistent with HIV, huge problem with TB. It comes out light blue because the relatively low proportion is multi-drug resistant, the kind that's really worrying, especially worrying. But that conceals the fact, because the burden is so high overall, there are over 10,000 cases a year of multi-drug resistant TB, and many we don't know about. And one of the things that one of the projects that our secondee Chikwe has got involved in is a first ever national survey of the extent of MDR-TB in the country, involving HPA staff over here as well. It's the first time they've done it to get a true picture of the burden of TB in South Africa. And he's involved in much other surveillance activities to do with TB as well. This is going to be of importance not just to South Africa, not just to UK, but to other European countries as well. Alongside his secondment, we've sent a group of registrars, public health registrars, trainees, doctors in training to South Africa over the last year. We've learned that having other exchanges during the period of one person being there constantly can be incredibly valuable. And this just gives you a picture. Louise, Aileen, Rachel and Sumi are all staff, junior staff, who've been over the last 18 months and got involved. This is in all kinds of important projects. This is a particular fungal skin infection down here in Mines. But again, it's expanded our global health involvement and created incredibly strong links between this country and South Africa. Significant public health outputs for South Africa. They are regularly writing to me to extend the secondments. And I think most importantly, the ongoing exchange of expertise, knowledge and learning. There's as much learning for us and for Europe through this exchange, these exchanges, than for South Africa. I said there was going to be a third reason why global health is important for Europe, and I believe that is the moral reason. That is that countries with higher income countries have a moral obligation to support poorer countries, lower income countries, especially when there is technical expertise that can be of assistance. And that is in spite of financial and economic crises. And I'm just going to give you a couple of examples of where we've been able to use that technical expertise to fulfill some of those moral obligations. We have 9 World Health Organization collaborating centers at the HPA. We're involved in a range of activities supporting, where invited, countries overseas. A couple of brief examples. We were invited in 2009 to Cambodia on the invitation of the Royal Government of Cambodia to work on infection control policy in their health facilities. And we sent 2 members of staff for a month, and they developed an infection control policy that has been implemented, and we're still involved in overseeing how well it's been implemented with them. This is specific to Europe, this was the toxic sludge incident in Hungary that some people may recall from 2010, and this was when the alumina plant discharged a swathe of toxic sludge that made its way down this village in Hungary. I think 1 person died, there was quite a bit of morbidity, significant environmental damage, as well as health damage to people, toxic fumes, and we are still involved. We've sent a member of our team, David Russell was involved. He's from that picture I showed you earlier of our chemical and toxicology expertise. We've been supporting the UN on the Global Platform for Disaster Risk Reduction and created, and I'm grateful for members of my team, Virginia Murray, Mark Salter and others, we've created with WHO a range of fact sheets for humanitarian disasters overseas, natural and man-made. You can go on the WHO website. These have been translated into a number of different languages. They're for public and professionals to access in the context of disasters as they happen. And those are just 3 examples of such fact sheets. So I've tried to give you 3 reasons why I think from the health protection perspective, being involved, staying involved, continuing to be involved in global health is important for Europe. Policy, public health and moral reasons. I think in some ways these have been captured very recently by what's happened over the last week, or the importance of this has been very recently captured. These are some of the press captions that have appeared on my desk this week. A number of HPA colleagues have been involved in the coronavirus that I imagine many have seen in the newspapers. This was the SARS-like virus. Coronavirus is anything from can be anything from a common cold to a SARS-like virus for SARS. and the 2 or 3 patients from Saudi Arabia and Qatar who have come into this country are now being ventilated, and there's been great concern about whether the virus that they've got is similar to SARS. Well, it's in the same family, but the infectiousness and the issues are not the same as SARS. But we have been heavily involved. We were involved in typing the virus over the last weekend. We've been involved in the infection control with St Thomas's and elsewhere. So we've been involved in the containment and the response to this incident. But I think what's important is the ability of the HPA to respond to this has been completely enhanced by the relationships we've built up over the last 2 or 3 years through our global health work with colleagues in Saudi Arabia, with colleagues elsewhere in the Middle East, and also with colleagues with WHO and the European Centre for Disease Control in Stockholm, who have all been involved over the last weekend. I'll stop there. Thank you.
Thanks very much. And so finally, Tom Hughes-Hallett, now in his new role as Executive Chair of the Institute of Global Health Innovation at Imperial.
Thank you, Andrew. So first of all, an apology. I'm an ex-banker whose wife in 2000 told him to go and do a proper job. And for the last 12 years, I've been looking after the dying and running Marie Curie in Britain and trying to work in Europe. In fact, we created a fantastic initiative called OpCare 9, working with 9 European countries with a grant provided by the EU. We showed that you can do it, you can learn from it. And despite the excellent point made by my young friend from Germany, you can also make extensive use of volunteers in improving care. And what was most interesting to me about that was that we also managed to convince the EU that there were 2 new European countries who we wanted to involve. And I was very excited about that, because those countries are those well-known European states of Argentina and New Zealand. And we sold it to the Commission on the basis that these were countries which we could learn from, rather than just being too European. So now I chair the Institute at Imperial, and I'm trying to work out what this institute is for. And I make that point advisedly in order to answer the question: why is addressing global health important for Europe? Well, I'm not actually terribly sure it is, to be frank with you. And the bit that troubles me is the word Europe. And Andrew knows me a little. I perhaps am too provocative sometimes, but I did a review for the government last year on end-of-life care, and I also did one on philanthropy. And I found having geographic boundaries around global concepts incredibly frustrating. And frankly counterproductive rather than productive. And I think my 2 colleagues have highlighted this fact. Disease does not recognise natural boundaries. And nor do people. And when I did the review of end-of-life care for the government year before last, the thing that really struck me is that end-of-life care in Britain is a global issue. Because the way in which you die in Britain is totally dependent on which community you are a part of and what conventions you subscribe to. For instance, for a West African family in South London, to allow the state or a charity to look after their family is an admission of failure. Whereas for others, it's the most wonderful solace. So I think we've got to be terribly careful about making this too European and just recognising it's a global issue, damn it, and address it in the best way possible. The second thing I'd say, which is perhaps more provocative, is as a new boy, and I am really new, so forgive me for being impertinent. I've been in my new job for I think about 11 days. So if you work for or with Aradar, I think technically he works for me, but I think actually the reality is different. As you can probably imagine, those of you know. And I certainly have realised it, by the way. I wanted it that way too. It seems to me as I've come in that this is an industry. Talking about global health is an industry. And there seems to be an awful lot of highly paid people circling the globe, not actually delivering much action. And please excuse me for saying that, but it kind of seems that way. I mean, everything seems to be about conferences. A number of people have approached me, very senior people from your world, and people you respect enormously and read their papers, and say, if there's one thing you can do, Tom, please make your contribution, given your character, to turning global health in a small way into global action rather than global discussion. And so at Imperial, drawing on all laurels, that's exactly what we're going to do. We're not going to try and do everything. We're just going to try and find a few things where, by using science, medicine, and technology and bringing them together, we can make a real change. Now, the good Mr. Bergström, who is from Sweden, I spent 11 years of my life working in Sweden, and I have a huge admiration for the Nordic area. Probably, in my view, the most innovative area in the world, probably, in the last, certainly in the 70s and 80s. And I worked with a young man in 1982. I set up an investment bank with 7 friends. We had no idea what we were doing, but it turned out to be quite successful. And one of the reasons it was successful was when we met another young man in Lapland. And he was working for a company that made gumboots, Wellington boots, rubber boots, forestry product equipment. And the thing they were proudest of, the thing in which they were global, was rifles. And they had a rifle which had been used in the Day of the Jackal. And this was the company's great claim to fame. And they were allowing their head of investor relations to play with an idea that they had, which they'd had to have because distances are so great in Finland. And there wasn't a huge amount of overhead cabling that they pinched from the sailing industry, which was mobile telephony. And this was a young man called Jorma Ollila, who went on to be chief executive of Nokia, and then chairman of Shell, and sort of kind of the rest is history. But I lived with Nokia, I was their investment bank, and I lived with Nokia through that phase. And I understood then that real innovation and affecting real change is often imposed upon you. So I want to tell you about 4 concrete examples of why we in Europe have to address global health. And all 4 examples are because otherwise we are going to fail and they will succeed. I find the phrase developing and developed world intensely patronizing. I've never come across it before till I came into academia. I really find it patronizing, actually. Because let's face it, the economies of the developing world are way stronger than those of the developed world, and growing rapidly in many cases. Some of the economic miracles, like Rwanda, where astonishing change is happening. It makes Newcastle, frankly, rather embarrassed, actually. And yet we sit here in this ground room thinking that we know it all, and we can bail these chaps out. If Europe gets together, we can save these guys. It's all going to be okay. In my view, it's quite the other way around, which we can learn from them. Mozambique. This is not my work. This is work that was done for the summit that ARA chaired on the 1st of August, when we got together 40 health ministers from around the world and heard about some of the things that are going on. Mozambique, infant mortality and maternal mortality was terrible. So what did they do? They reduced infant mortality by 75% in a very short period of time by training health workers to carry out caesarean operations. 92% of caesareans in Mozambique are now carried out by what they very cleverly called surgical assistants. But they are actually trained healthcare assistants, really. And the costs have been reduced from $144 to $39. So much cheaper, fewer people die, and the quality just as high. In China, they've adopted a new prescriptive health policy across a very large province of China, which is they have withdrawn salt from sale across an entire province of China and replaced it with low sodium substitute. No one has complained. Wouldn't dare. No one has complained. I didn't say that last bit. No one has complained. And health has improved. Could a town in Britain or France or Spain actually, through its planning department, democratically refuse to have fast food chains in their urban environment in order to improve rates of health in non-communicable diseases? Ask yourself that question. It would be prescriptive policy, but it's perfectly available to all of you. It's just that we're all too frightened to do it. And then I want to tell you about dear old Tonga. Tonga has introduced a self-management program in asthma. In the year previous to this experiment, 84% of patients in Tonga with asthma had had an emergency admission to hospital. In the year of the experiment, those patients then attended a clinic where they were given a PEF bit of kit so that they could monitor their peak expiratory flow. That 84% in the previous year went down to 18% in the following year. And severe asthma attacks fell from 54% to 18%. Why aren't we doing that in Glasgow? Why aren't we doing it in Stuttgart? Why aren't we doing it in Paris? And then the final one, which I find the most profound of all, and actually, to be honest, the most controversial, that segues neatly back to the first speaker, so you can get it here with the first question. The poly pill. How many of you know about the poly pill? Quite a lot of you. So the poly pill, combining 3 drugs together in low doses and compulsorily effectively, giving them to 100% of the population at 55. They thought this would reduce incidence of heart attack or stroke by 80%. The trials have been disappointing in the pills made in Iran, Spain, and the US. Disappointing because instead of 80%, it only reduced it to 60%. So here is a low dosage pill that is there. It's being made in Iran, Spain, and the United States, and where India has grabbed it and said, we want to go with this. We really want to give this a try for our population. And I think that's another area where we need to learn from the developing world, to use my least favorite expression, which is around regulation. Because actually the real reason why Tonga's experiment, Mozambique's experiment, and China's experiment will not be adopted in Europe, probably, is the entrenched position of medical and clinical practitioners who will see it as job threatening. And secondly, this whole area of safety and regulation, and a fear of trying something new. And this morning, a fellow gynecologist said to me, who practices in a hospital in London, I know that if I gave more of my lady patients HRT, they would be happier and healthier. But now the paper has come out that shows there may be some risk. I no longer dare to do it, though they want it, and I know they will be better people for it. I'm not sure that sort of mentality has crept in yet, and so we can learn. That's me.
Thanks very much. Plenty of juicy subjects to come back to, and thanks above all for those concrete ideas and models, which is very good to focus on. Though I have to say, as somebody who started his training as a geographer, I do think place still matters, not because disease might respect no boundaries, but money and policy making certainly does still very much depend, obviously, on national and local level decision making, as you also pointed out later. But let's just go back the high view. You know, we're talking about economic crisis, interaction with public health, global health, and sort of foreign policy, I suppose, in a sense. I mean, maybe start with you, Anthony. Just give us a sense of kind of post-2008, maybe in Europe, and from what you see of the globe as the HPA. I mean, do you see that those economic pressures actually having a significant impact on, as it were, the global health trends that you're observing either within the UK or more internationally? You know, you might posit migration changes, trade changes, cost-cutting issues, pressures.
If I can just touch on 2 things that have been going on in parallel. Obviously, there's the changes of two big policy changes, the changes to the public health system and the changes to the NHS. And in terms of the changes to the public health system, which will involve, for instance, the Health Protection Agency becoming Public Health England next year, actually the public health system, you and I were talking a little bit about this beforehand, certainly the HPA and Public Health England, I think is in a reasonably good shape. And there's strong support for public health in this country. We've already got one of the best public health systems in the world, thankfully, in this country. And I hope that we'll be able to strengthen it further. And the messages that I've been getting so far, and I will continue my own global public health, the global health role for public health in Public Health England, is that we carry on and we wish to expand. We wish to involve more public health staff in the UK with colleagues overseas in some of the work that we're doing. So, and that is not the same picture as in the NHS, where the financial crisis, I think, is hitting much harder. But in the public health system, our ability to stay involved in global health work, I believe, will continue. And that is exactly how we are operating and planning at the moment, which is a good thing. The one thing I think we probably haven't done as well as we could have done is connect the work that we're doing in the UK with other countries in Europe, and indeed with other countries elsewhere. We have taken the approach, I think, that touches on what you were saying, that we just get on and do it and get involved. These are very practical examples that I've given of the work we've been involved with, but I think there's more work that we could do around connectedness between countries on how we work with other countries globally.
And I'd like to come back in a minute on the connections and bilateral and multilateral links, as it were, but maybe just go to the other panellists in terms of that issue from the top level, what you see as the pressures from the economic crisis and how that's driving both, the challenge of disease and the response of players, whether it's industry or government, for example.
Yes, two thoughts on that. One which I just mentioned briefly, and it touches on what I said earlier. That was very encouraging, at least for me, and having, of course, a bias working for the pharma industry, but very encouraging, at least in Europe now in the crisis, is that everyone that I meet and all of my ministers of finance even realize that somehow, you cannot turn off the pipeline of innovation, and that means both your research budgets. And actually, I listened to your Minister for Science yesterday in a panel debate, and protecting the research budgets. So wherever the research asking for more money, he said you were protecting it. I think it's a fair point these days. So you protect that, and then also you somehow protect us a little bit, the part of us. So you can cut heavily on certain prices, but not maybe shut off the flow of new products because you need to still incentivize that, and that's very encouraging. What I see across Europe now, and spending a lot of time with various ministers, as I said, and Troika and DG ECFIN and these people, OECD and so on, is of course that all of us in the health business, if I call it that, the health sector, we are not that well equipped to stand up to the economists and the ministries of finance, because they come in and they say. They all somehow know that we waste a lot of money. They know it's not particularly effective. But they don't know where to cut. So they rely on us to do that. And then we get sort of stuck. And as Sir Tom was alluding to that, we can go back to that later, the whole area of regulation, turf, and structures and rigidity. So of course, maybe you know that is that those hospitals that needs to be shut down and replaced by small, nimble, effective primary care units with more nurses than doctors maybe, and so on. But that's very difficult to do. What I also encounter when I meet these people is that they operate from very high-level data sets. Of course, it should all be evidence-based, right? So they come with numbers, and then in the health area, the only numbers, and I heard this was OECD project leader for this, the only number that's really good for them to work from is the life expectancy at birth. Because they don't have reliable numbers on asthma care and outcome in different countries, particularly when you compare this. They go into a country, and the countries that are in trouble usually have the less data than the others. So you don't have no clue. So the only metric you have is basically, what they cost and the life expectancy at birth. And then you plot this And if I would have shown one slide, it would have been that one. You know, you've seen it all, you plot this. And then there's one favorite OECD slide which says there is poor correlation between expenditure and outcome. Because up to a point, up to, you know, $2,000-3,000 of spend per year, you know, then you actually see dramatic increase. And this is what we've seen in Mozambique around other countries, how they basically lift themselves extraordinarily with comparatively small investments. But then we all know that, you know, the Swiss pay double from the French, and their healthcare is not double that of the French. And we know the Americans spend even more. So somehow, the economists are therefore telling me, I'm simplifying, Minister of Finance telling Minister of Health, well, you can take 25% out here without any impact on health. Was that what, you know, that's it. So we're very bad in what I call reverse engineering all the evidence we have for individual interventions, because we introduced certain things based on evidence. Nice, HTA, good, do this, that drug, you know, that procedure, build another hospital, you know, you convince the politicians to the trust, you being convinced to build another unit, and you do that, and it's all cost effective. Right? But then to unwind that, you have to save some money. We can't reverse it, and we don't have the data. And we don't have the data in the aggregate for why we spend X on asthma care or X on certain medicines. So this is where I don't know if I have any solution. This is an observation. I'm not suggesting we should all go get degrees in economy, or that we should spend all this time in gathering data necessarily, but just that we have to be aware of that debate that takes place.
Okay, Tom, any thoughts are in there? As you say, of course, the other parts of the world, well, the BRICS, of course, are doing, as you say, much better. So clearly, the Eurozone crisis isn't a total global crisis by any means. But how do you see that evolution and the pressures driving policy and health?
Well, I'll start with aspiration and then perhaps reality. I mean, my aspiration, I was running a bank at the time of the 87 and 89 crashes. And the banks that did well ignored the crash and stopped reading the Financial Times. They still bought it, actually. They won. But it's very easy, I think, to become rabbit-like in a set of headlines. And the thing is that patients don't actually change based on economic circumstances. They're still sick, and they still need us. So my aspiration, and I am an eternal optimist, is that this is a real opportunity. Because I think it's a serious opportunity for innovation in places where it should have happened a long time ago. And this is a wonderful excuse to allow people to make change that might have just been too difficult before. And an example in Leeds would be 2 years ago I convinced them not to have social care for end-of-life patients and healthcare for end-of-life patients. But because they said they couldn't get on together. So I said, well, I'll tell you what, I can save you 50% of the cost. But how do you do that? I said, we'll get rid of both of them. And we'll just have one end-of-life care person who washes above and below the waist and provides health and social care. It's been a massive success. And interestingly, most of all with the workforce, who love it, because it's a much more interesting job, because it has variety in it. Patients love it, because they don't have to see two people, they only need to see one. And Leeds love it, because it's costing them less money. So I think aspirationally there's a chance here. And in the context of today's conference, I think it's a wonderful opportunity for Europe to work together, actually, to say that we've all got the same problems. I take your point about geography, and I wasn't very good at geography. I could never understand what an oxbow was. But so I do think it's a driver to bring us together. Reality, however, is that I hear more and more politicians saying we're not prepared to make that change without the evidence base. And this is something that Ara and I have always agreed. I sat on the NHS's innovation board, and Ara put me there because it was full of very clever people. And if he had one stupid person there who put his hand up occasionally and said, well, why can't we actually? And I think we're slightly in that trap at the moment. The policy makers in Europe will say we need the evidence before we make the change. And for those of us who aren't as clever as the policymakers, we think, and of course we're wrong, obviously, that you can't collect the evidence until you make the change. But now that I work in the world of policymakers, I understand that obviously the policymakers have to be right. But joking aside, this is a serious problem. We have to be brave enough to trial change, to adapt to these big economic issues. And we've got to encourage the policymakers to be that brave and be courageous, rather than demanding the evidence before they'll let us give it a try.
I'd like to come back.
This reminds me, you've all read or heard about, Steve Jobs' legacy, of course. He never did market research. Because I saw this great quote, why would you go ask customers what they want if they don't know what they want? And there was this great article about him and about history, and he had made some failures. There were some failures. I think one of these first PC-type computers he developed, which was sort of plastic and very ugly, and it didn't take long. And a few of those as well. But then there were those few successes that really afterwards carry, I guess. So I being also a policy person, I also ask myself sometimes, if we are overdoing the evidence gathering before we take action.
There's another interesting thing about Jobs is the secret was marketing success, wasn't it? But it's interesting in health compared to so many other sectors, how, going back to your point, regulation gets in the way of any sort of direct contact to patients as consumers, for example, and driving change.
Well, the doctors as our customers, not the patients. It is a bit strange.
And maybe coming back on it.
Now governments take over, we deal with that instead.
Entrenched conservative interests, clinical practice and regulation, that's fair. Do we need to challenge that much more aggressively?
Well, I'll come back. I was just actually going to touch on the evidence base, so you might not be surprised as a public health professional that I'll just challenge that issue of not so much the policymakers being brave, but the issue of implementing or trying to implement change without an evidence base. I think it's vitally important that we enhance creativity in terms of implementing the evidence base. I was just thinking, all four examples you provided actually have an evidence base. So the polypill, self-management of asthma, salt, and C-sections not being done by doctors are all from research that have an evidence base. What's interesting about the examples for me is that they've been creative solutions to, or attempts to produce interventions that work in a particular context that is not necessarily the higher income context. And they should be attempted, and that kind of creativity should be encouraged, and it should be evaluated, of course, because they may or may not work.
But why only not in a higher income context? Why couldn't we trial this in Gloucestershire?
No reason. So I was talking about the global health context in terms of countries outside our own. But no, absolutely here, and we do some of them.
The polypill has been trialled.
But can I just say something on the polypill? Yes. So the evidence is there for these components. But why isn't there a polypill on the market here? Why not?
I don't know.
I know. I tell you
Because you don't know, we're all going to give up.
I started, my first job was actually working in a similar position like you do. I worked for the Swedish government for the what's here the MHRA approval, because the regulators require that you do new clinical trials to put three things together. New clinical evidence is going to get approval. You can't just put three things. Low dose, low sartan, whatever. These are all generic now. Low doses of these, put them together. You need to do new studies, new clinical studies. It's going to cost you hundreds of millions of euros or pounds to develop this. And all the regulatory requirements are there. And these products are off patent, which means that no one's going to invest it because it's generic. And then if someone gets the approval, anyone can copy it. So it's to Tom's point again, that there are some regulatory structures that we've learned to live with them. We call it this regulatory capture. It goes both ways. Sometimes the regulator is captured by the industry regulation, but it goes the other way around as well. Because we in the industry, big pharma, we've been adding thousands and thousands and thousands of people, and we do longer studies, and more. If the regulators say we need this, we add it. It adds to the development cost, it adds to the price. No? And it's not until now when we have NICE saying enough is enough that we actually start thinking about this is not too expensive. We have to figure out how do we unwind this, but that's easy said than done. So I think so Tom is on to something, and it's just need to find that right balance between the correct scientific evidence to do the right things, but then sometimes the requirements for evidence and regulation just gets in the way. Polypill is not available anywhere, basically. It's not in India either. They don't have the money, by the way, anyhow, to pay for it. If someone had it there on the shelf, the Indian government would not have sufficient funds to reverse it. But that's another debate.
It's just a final thing before we open it up, but just coming back to your point on coordination. So, I mean, is the problem actually too much, as it were, central coordination in Europe would still further stifle innovation, let's say, or actually do we need to rethink and have tighter cooperation, in your case, for example, between CDC, WHO even, as well as national health protection agencies, regulators and so on? Would that help tackle more effectively the challenge of disease within and beyond Europe?
My own view is better coordination would be a benefit. We do have the situation where some countries have or present more public health resources, money, expertise that they're willing to, or able to, or prepared to spend on global health work than others, and that's part of the reason why we just got on with a lot of things. I do think the issue of medical and clinical threats to professions is a really, really important one in terms of stifling innovation. And I produced an example. I was thinking about Nigel Crisp's work in Zambia, and the innovation in terms of using non-clinical staff or non-doctors, whether it's for cesarean sections or other public health and clinical activities, is incredibly important. And it tends to be, unfortunately, that what happens is in a country with poorer resources, they try it out because they're obliged to, whereas actually here, we should be trying out some of these things, and the profession gets in the way sometimes. That is not a good thing, but it's hard to challenge and break. There's no reason why, like the example of end-of-life care, there's no reason why we shouldn't change things here, but there's entrenched views.
Andrew, can I just come in on that? Having worked in the voluntary sector for a while, the only thing I do slightly wonder is whether statutory bodies are the right people to coordinate. I mean, it would be, and when I say statutory bodies, I really mean governments, or whether actually governments should fund and enable others to actually voluntarily and encourage them to coordinate. We should be giving prizes for intra-European health innovation for global problems, so that people want to do it. There's something that I just found in the voluntary sector what really, I led a program in Lincolnshire where we increased home death rates in Lincolnshire from 19% to 42%. And it took us 3 years to do that. And that program has now been rolled out over more than 30% of Britain. But if I started with an instruction from John Reed, who was then Secretary of State, to do it for him, I bet it wouldn't have worked. There was something about encouraging people to come together. Now, we had no evidence base to show what we were doing was right. So I persuaded the Marie Curie trustees to put £7 million on the table to allow us to do 3 pilots. And they were all, one was Leeds, one was Lincolnshire, and one was Tayside. They don't do pilots in the northeast of Scotland, the eastern border of Scotland. But that's another story. But the wonderful nurse at Nine Wells Hospital, who said they were born here and they can die here. There's no need for them to go home. I just feel that being told to do things doesn't get people to do them. I think we've got to incentivize people somehow to think it will be fun and exciting and that we'll affect change. We will actually affect change in the south or in our own European patch by coming together. And maybe that's how European governments can help most, actually, is to facilitate that willingness. Is that a bit wishy-washy?
No, that's very concrete. That's good. Any further thought, would you?
Maybe the European pharmaceutical industry should fund it now, I think.
What would you want?
There's no money left. We don't,
do
you see,
more for you?
these days we don't get paid. We have about, I think now, 12 billion euros of outstanding invoices that we haven't paid. It was used to be about more than 15, but it's down to 12 or something like that. I think two reflections. One is that I actually do think that the geography sometimes do matter. You have to decide, because if you want to collaborate, you have to decide how broad you want to collaborate. And it's a convenient size, Europe. And there's still so much we do where we don't collaborate. If you take HTA, NICE was mentioned. I mean, we have 27 EU member states. We have 45 or 48 agencies. And only 1 or 2, 3 of them really matter. NICE certainly matters. I mean, we feel that we're not happy all the time. In some of those Scandinavian countries as well. But others, many of these don't. Too provocative, but no one pays any attention. You do this nice HTA review and you say that this or this should be used and not used, and then it has an impact on medical practice. So if you could all do that much earlier, you could do it together in Europe. At least you'd spend less money and time on doing something. I think there's a lot of going on in the public health space as well that I think can be certainly coordinated. Europe is altogether just a quarter of China or whatever, or a third of India. I mean, we don't have these days. We must really look after where we spend the money. Now the other thought is a loose connection. Just reminds me of this conversation I was in yesterday. I was in a debate with your Secretary of State for Science and Higher University, Freeman. Yeah, brilliant man, by the way. And we were discussing, there were a couple of persons there, we were discussing systems of innovation, and Charles from Oxford was there, and a few other also, people that are involved in translation science. And the fact that the pharmaceutical industry is changing from having believed that you do everything in-house, and it's from cradle to grave, back to the diner, you do everything, you have everything in-house, to being much more virtual organizations. You work with academia in a whole different way. We have open innovation, used to be a bad word. We scramble for partnerships. Companies go together and share all their secrets in order to really deliver all the science that I alluded to earlier. So I think maybe there's something to learn also on the public side, looking at how the private sector, now probably other industries as well, that are changing with the times, they're moving with globalization. And what governments can do is that they can nudge us, if you use that term. They can put a little bit of money on the table to get things going. Many of these European research partnerships now, it's not always that much money, but what they do is that the Commission can capitalize that people come together under a safe flag, the EU flag, and you can suddenly work together. You can work with Big Pharma if there's an EU flag hanging on you, because then it's easier. And it's more transparent, actually, that helps also. So that's some food for thought, maybe.
Okay, thanks. Let's open it up. You might, yes, please.
My name is Andrew.